everyone, it's Dr. Mears again, and in this lecture, Dr. Theeler and I are going to talk about the structure and function of the facial nerve, and of course, some of the clinical conditions related to dysfunction of this nerve. So these are the learning objectives, which you can pause to read. I'll be covering numbers 1, 2, and 3 in my portion, and then Dr. Theeler will cover objective 4 in his portion. In this first part, we're going to talk about the function and the course of the facial nerve, and the good news is you've seen bits and pieces of the facial nerve in different lectures and labs already in the module, so a lot of this is going to be review and putting things together. First and foremost, you always want to think of the facial nerve as the major motor nerve for facial expression. It does have other functions, and those are clinically relevant, but the main function really is that control of facial expression. And so when you see a patient that has weakness of facial expression, which happens a lot in the clinic, you'll always associate that with the facial nerve, and that will help you with your clinical reasoning. This slide shows schematically that the facial nerve has 4 components, and of course the major component is that motor component. These are lower motor neurons, and as you'll see, those are found in a nucleus called the facial motor nucleus in the pons, and the axons of those neurons are going to course out with the facial nerve and its branches to innervate the muscles that are derived from the second pharyngeal arch. Remember, most of those are muscles of facial expression. It also has parasympathetic component, and these parasympathetic neurons are also found in the pons, and their axons will go out with 2 of the branches of the facial nerve that we'll talk about momentarily, ultimately controlling secretion from the lacrimal gland, the nasal mucosa, and 2 of the salivary glands. The facial nerve also has 2 sensory components. The special sensory component, as you remember from before the midterm, is carrying taste from the anterior 2/3 of the tongue, and those fibers are going to synapse in the solitary nucleus in the medulla. And then there's a very small general somatosensory component. These fibers are carrying pain and temperature and touch type of information from a small region around the external ear, and those, as you recall, will be synapsing in the spinal fifth nucleus. So the course of the facial nerve is quite complex. It's kind of hard to show on schematic drawings like this, but this drawing, I think, does a fairly good job of it. So you remember that the facial nerve attaches to the brainstem at the cerebellopontine angle. It's got a large motor root and a smaller intermediate nerve with the other components that will eventually join. And the facial nerve will then course through the posterior cranial fossa and enter the internal acoustic meatus. And then the next part of the course of the facial nerve is going to be encased within the petrous temporal bone. And so within the petrous temporal bone, it's going to take a sharp bend, and at the location of that bend is the geniculate ganglion, which has the cell bodies of the sensory neurons of the facial nerve, and that's also where it's giving off its first branch, the greater petrosal nerve. As it continues along, it's going to be in the walls of the middle ear cavity. Remember the medial wall, and then curving down along the posterior wall, and that's where it's going to give off the chorda tympani branch, as well as a small branch that is motor to the stapedius muscle, another second arch derived muscle. Finally, the facial nerve is going to exit the petrous temporal bone through the stylomastoid foramen. It's going to enter into the parotid gland and give off its terminal branches. Of course, are the terminal branches. You saw these in the lecture on the face. The mnemonic for these are to Zanzibar by motor car for these 5 branches, which are purely motor, streaming across the face to innervate muscles of facial expression. Okay, so here in part 2, we're going to talk about 2 of the major branches of the facial nerve that come off while it's in the petrous temporal bone. These branches actually don't innervate any muscles, but they are carrying out the parasympathetic and the special sensory functions of the facial nerve. So the first is the greater petrosal nerve, and this is a purely parasympathetic nerve. It contains those parasympathetic neurons that ultimately are going to control secretion of tears from the lacrimal gland, as well as secretion from the nasal mucosa. So this is a superior view of the cranial fossae. We've cut away the petrous temporal bone so we can see into the internal acoustic meatus and into the middle ear. And so again, the facial nerve is coming down through the internal acoustic meatus, and when it gets to the end of that, that's where the geniculate ganglion is, those cell bodies of the sensory neurons. And here where the facial nerve is taking that sharp bend is where it's giving off the greater petrosal nerve, and that's going to course down along the anterior face of the petrous temporal bone over towards the foramen lacerum, which you remember is one of those openings in the middle cranial fossa. This slide shows schematically the very complex course by which we get parasympathetic innervation to the lacrimal gland and the nasal mucosa. You certainly don't have to memorize this entire slide. The names of the structures that you probably want to remember and we'll hear about again as we go through the module are shown in red. So the idea here is you have these parasympathetic fibers that are coming out of the brainstem and they're coursing with the facial nerve, and some of these fibers are going to go off with the greater petrosal nerve, course down to the foramen lacerum, and that's where the nerve is going to get met by some sympathetic fibers that came up from the neck, from the superior cervical ganglion. You don't need to worry about those too much, but at this point the nerve is going to be called the nerve of the pterygoid canal, and in an upcoming demonstration you'll see that nerve of the pterygoid canal coursing through a little bony canal at the base of the skull to reach a very remote area behind the nasal cavity called the pterygopalatine fossa. And that's where the pterygopalatine ganglion is. That's where these parasympathetic fibers are going to synapse. And then the postganglionic fibers coming off of that ganglion will jump onto branches of V1 and V2 to reach the lacrimal gland and the nasal mucosa. So again, you don't have to memorize this whole complex course, but if you understand the function of the greater petrosal nerve, you'll know that when the nerve gets injured, which doesn't really happen too often, maybe with trauma to the petrous temporal bone, an isolated injury of that nerve is going to cause a reduction of lacrimal secretion as well as secretion from the nasal mucosa. And the big part is usually the lacrimal secretion causing dry eye, which can make the eye susceptible to ulceration as well as infection. And so the second branch that we'll talk about here is the chorda tympani. And so you remember from the lecture on the ear, this is going to come off as the facial nerve is coursing through the petrous temporal bone. Here is a cutaway of the petrous temporal bone. It's as if we're sitting in the middle ear cavity looking at the wall of the inner ear. This is the facial nerve coming along the medial and posterior wall of the middle ear cavity. And here it's going to give off the chorda tympani, which you remember will course up back over the pars flaccida of the tympanic membrane. So the chorda tympani has parasympathetic fibers as well as the taste fibers from the tongue. And this is again a schematic drawing of its course. So after it works its way through the middle ear cavity, it's going to end up in the infratemporal fossa, another remote region that you'll be seeing in an upcoming demonstration. And within that fossa, it's going to join up with the lingual nerve, a branch of V3, and then the lingual nerve is going to carry those fibers down into the oral cavity. Remember, you saw that lingual nerve coursing in the sublingual region back when we studied the oral cavity. And so if you picture a parasympathetic neuron starting up in the brainstem, its axon is going to course with the facial nerve, take that bend, come off with the chorda tympani, work its way down through the infratemporal fossa, join up with the lingual nerve, and ultimately synapse in the submandibular ganglion, that little ganglion hanging down there off the lingual nerve, and then the postganglionic parasympathetic fibers will distribute to the tongue, rather to the submandibular and sublingual glands to control their secretion. And then, of course, the chorda tympani also has taste fibers. The cell bodies of those fibers are up there in the geniculate ganglion. Their peripheral processes will be innervating. Taste receptors on the tongue, coursing back first with the lingual nerve and then the chorda tympani, and then ultimately the central processes will course with the facial nerve and end up in the solitary nucleus in the medulla. So remembering these two functions of the chorda tympani, you'll understand that when this nerve gets damaged, for example, which can happen if there's a problem with the eardrum, so perforation of the tympanic membrane can damage the chorda tympani, you're going to get loss of taste sensation on the ipsilateral side from the anterior part of the tongue, and you'll also have some reduced salivary secretion. Again, you still have your parotid glands and two other glands innervated by the facial nerve on the other side, so you probably won't get noticeable dry mouth with an ipsilateral lesion, but if it's bilateral, then you might have the patient complaining about dry mouth. So here in part 3, we're going to introduce an important concept, which is facial nerve palsy. And so that's basically weakness of facial expression due to dysfunction of the facial nerve. And so you will see this a lot clinically. And when you see this type of weakness, like any other kind of weakness, it's going to be very important for you to be able to determine whether that weakness is caused by damage to lower motor neurons, in which case we call it peripheral facial nerve palsy, or upper motor neurons, in which case we call it central facial palsy. And so in this part, I'm going to talk about how you tell the difference between those two conditions and the anatomical basis for that difference. So when the facial nerve gets damaged, or more precisely, when the lower motor neurons of that facial nerve get damaged, you're going to get what's known as peripheral facial nerve palsy. And basically that's going to cause weakness or paralysis of all of the muscles of facial expression on the ipsilateral side. And this condition was described already in the lecture on the face. So just to review, when we have that weakness of facial expression, the face is going to kind of get flattened out. So we're going to lose the wrinkles on the forehead. We're going to get flattened nasolabial fold. We're going to have trouble closing the eye and the mouth. So widened palpebral fissure, difficulty blinking, perhaps drooling coming out of the mouth because of inability to close it. Going to get that asymmetric smile, and then potentially difficulty with whistling and sucking, food trapped in the cheek. These are both manifestations of weakness of the buccinator muscle. So clearly this patient would have a peripheral facial nerve palsy on the right side. Now we can also get weakness of facial expression due to problems with upper motor neurons, the upper motor neurons that control the motor functions of the facial nerve. And that pathway is called the corticobulbar pathway. So remember back when we did the spinal cord, we talked about the lower motor neurons being way down in the ventral horn of the spinal cord. And then we had upper motor neurons in the cerebral cortex whose axons went down as the corticospinal tract in order to provide controlling inputs to those lower motor neurons. So in the case of the cranial nerves, the lower motor neurons are located in the brainstem. And you already saw the nucleus ambiguus and the hypoglossal nucleus in the medulla with the lower motor neurons for cranial nerves 9 and 10 and cranial nerve 12. And in a short time, you'll see the nuclei in the pons that contain the lower motor neurons for cranial nerves 5 and 7. There's also nuclei that contain lower motor neurons for moving the eyes, but it turns out that the corticobulbar pathway does not control eye movement. So we're not going to talk about those nuclei anymore in this lecture. So these lower motor neurons for the cranial nerves, like all lower motor neurons, need to get controlling inputs from the higher brain regions. And those neurons are located, as you would expect, in the primary motor cortex. And because the cranial nerves innervate muscles in the head and neck region, it's going to be the face region of the motor homunculus down there on the lower part of the motor cortex. And so these corticobulbar neurons are going to send out their axons. They're going to descend down through the brain into the brainstem as the corticobulbar tract, located very close to the corticospinal tract through its course. And those are going to innervate these lower motor neurons in the cranial nerve motor nuclei. Now notice a key difference here between the corticobulbar pathway and the corticospinal pathway is that the corticobulbar fibers innervate most of the cranial nerve motor nuclei bilaterally. So these lower motor neurons are receiving controlling inputs from both sides of the brain. And that's very important because it means that if we get a lesion of the corticobulbar pathway on one side, most of the cranial nerve motor functions are not going to be affected because they get inputs from the other side of the brain as well. So with this type of lesion in the corticobulbar fiber, we won't have trouble, for example, moving our tongue, jaw muscles, swallowing, speaking, things like that. But the facial motor nucleus is unique, and its unique pattern of innervation is going to have important clinical consequences. So we need to look at this in more detail. So here's the facial motor nucleus down in the pons, and you can kind of picture this as divided into two parts. So there's an upper part that has the lower motor neurons that are innervating the muscles of the upper part of the face, and we have a lower part that has the lower motor neurons for muscles of the lower part of the face. And the way this works is that the upper part of this nucleus, like all of the other cranial nerve motor nuclei, is receiving bilateral input from corticobulbar fibers. But the lower part of the facial motor nucleus is only receiving crossed input that's coming from the other side of the brain. So what that means is if we have a lesion of the corticobulbar tract here above the facial motor nucleus, the muscles of the upper face are not going to be affected. They're still going to work fine because these lower motor neurons still get controlling inputs from this side of the brain. But the lower part of the face is going to have weakness of facial expression. So the side contralateral to the lesion, because again, this only gets crossed input, we disrupt that input and we're going to have weakness of those muscles. And so this slide shows the key differences between the peripheral and the central facial palsies. And so you're going to get used to recognizing this in patients and in clinical vignettes. The idea is when you recognize that there's weakness of facial expression and it's the entire face, including the upper part of the face, you're immediately going to think that that's peripheral facial nerve palsy. And because this is affecting both the upper and the lower eyelids, if you test the blink reflex, that's where you swipe the cornea with a swab and look for a blink. There's not going to be any blink because both eyelids have that weakness. In the case where you see that only the lower part of the face is affected, and when we say lower face, we basically mean lower eyelid and below are weak, but the upper eyelid and the forehead are fine, then you're immediately going to think that this is a central facial palsy. There's been a lesion in the corticobulbar tract over on the contralateral side. And in this case, when you test the corneal reflex, you swab the cornea, because the upper eyelid is still working, you will still see blink response in that eye. There's also a difference between these two conditions in what is known as mimetic or emotional facial expressions. These are the facial movements that we make in response to emotional stimuli. So they're sort of involuntary things like smiling, laughing at a joke, frowning, expressions of fear, so on and so forth. In the case of central facial palsy, because there's still a connection from the brain to the facial muscles, you can often still see emotional facial responses. And that's because the pathway that controls facial expression for emotion is independent of the corticobulbar pathway. So if you ask the patient to voluntarily smile, the smile will be asymmetric. But if you can tell a funny joke and make them laugh, you'll actually see facial expressions on both sides. That will never happen with a peripheral facial nerve injury because the facial nerve is damaged and we can't get any signals out to make those muscles contract, whether they're emotional or voluntary in nature. And with that, I'll turn it over to Dr. Theeler, who'll talk about some more important clinical conditions that affect the facial nerve.
Hello, first-year students. I'm Dr. Theeler, and I will be adding some clinical correlation and talking about some cases after year-term review of the 7th cranial nerve with Dr. Mears. Let's jump right into a case. So we have a 45-year-old patient who presents with the chief complaint of being unable to move one side of their face. It started about a week prior. No illnesses and no past medical history to report in this patient. And you can see that the one finding on exam is pictured on the right. Everything else is normal. What is the most likely diagnosis? I want you to pause here, think about these answers, give your best one, and we'll go to the next slide and talk about it. So the best answer here is D, idiopathic facial nerve palsy. We're going to talk more about that diagnosis on subsequent slides. Let's go through a process of elimination and talk about why these other answers are not best. So this is not a middle cerebral artery stroke. This patient has a peripheral, not a central pattern of facial paresis, with the patient in the bottom right having a central facial paresis with some sparing of the upper face. So B here for Waldstrom syndrome is a rare syndrome associated with an autoimmune disease called sarcoidosis. I'm not expecting you to know this. This is something to perhaps throw you off a bit, but also these are patients that have a peripheral facial nerve palsy and other findings. So there are some tumors that can involve the 7th cranial nerve, either of the brain or the parotid gland. These patients you'd expect to have a longer term, more insidious onset over a period of months and do not have a clinical course like an idiopathic facial nerve palsy. They're also much more rare. So the best answer here is D. So to talk more about central facial palsies, since I think this one comes up in both your reading and as you're learning about this, is there's this idea of a central versus a mimetic facial nerve palsy. So the patient on the top has a stroke in the left middle cerebral artery distribution in the motor strip, and as a result has a right central facial palsy you can see in the top A block there, okay? Now, when you tell that patient a joke, they will overcome that central facial palsy and be able to smile. That is because the pathways that control voluntary facial expression and emotional smile are different. And that's shown by the case in the bottom. So this is a patient who has a stroke deep in the right frontal hemisphere. Now, she may have a little bit of a left central facial palsy, but that gets much more pronounced when you tell her a joke. So this is what's called a left mimetic facial palsy, someone who has a deficit of an emotional smile, which is something that you will come across much less frequently than you will what's going on the top of this with that top case. So let's go back to our first patient, okay? So what are some additional questions that you may ask? So I'm going to ask you to pause here, read through these answers, think about your answer. We'll talk about it on the next slide. So the answer is E, all of the above. And let's sort of take a neuroanatomic approach to discussing why that would be the case. So as you've already been told, so the seventh cranial nerve goes into the internal acoustic meatus and then comes out the stylomastoid foramen. It's those most peripheral branches that control voluntary facial expression, right? But there are other branches that actually come off of cranial nerve 7 that can be clinically relevant. And let's talk about that some more. So if a patient has a peripheral facial nerve lesion on one side, they can have other deficits on the same side as the weakness. One of those would be hyperacusis. So the stapedius muscle dampens sound. So if a patient has involvement of the nerve to the stapedius, they can actually hear sounds louder in one ear than the other. If patients have involvement of the parasympathetic fibers, they may have reduced tearing, or they may have reduced salivary secretion, or reduced taste on the anterior 2/3 of the tongue. And again, those will be on the same side as the weakness. Now, it's not often taught, but the facial nerve does actually have a small sensory distribution behind the ear and in the ear. So patients who have a peripheral facial nerve lesion may actually have an area of neuropathic pain either in or behind the ear. So what are the etiologies of a peripheral facial nerve palsy? So the most common cause by far is a Bell's palsy or an idiopathic facial nerve palsy. But there are some other conditions that can involve the seventh cranial nerve, usually in specific clinical scenarios. So patients who have skull-based trauma, especially at the area of the stylomastoid foramen, may have a peripheral seventh nerve lesion. Patients who have certain infections like varicella zoster virus or Lyme disease can have a peripheral facial nerve lesion, usually associated with a specific pattern of rash. There are certain tumors, for example, a facial nerve schwannoma, as shown in the top right picture, which can involve cranial nerve 7, often nearby cranial nerve 8. A cerebellopontine angle meningioma, which can grow right where cranial nerve 7 and 8 leave the brainstem. These are both in situations where, again, you'd expect more of a chronic presentation. So patients who have a seventh nerve palsy around birth, that can be due to trauma or certain genetic or congenital syndromes. And there are certain inflammatory and autoimmune conditions. For example, Guillain-Barré syndrome, which you'll learn about later, is a condition that can cause an ascending pattern of numbness and weakness. Those patients can also have involvement of the cranial nerves, including cranial nerve 7. And then I already mentioned sarcoidosis as a condition that can involve the base of the brain or the parotid gland and be associated with the peripheral facial nerve lesion. So what is a Bell's palsy, right? And so that's what you're usually going to hear this called. And so what does that mean? So usually that is used in the place of idiopathic facial nerve palsy, or I should say an idiopathic facial nerve palsy is called a Bell's palsy. And of course, this is a very famous person who was very open and talked about her own bout with the Bell's palsy. So why is it best to say idiopathic facial nerve palsy? Well, First of all, that's a very specific diagnosis with a specific clinical course, and patients usually improve over time. The cause is unknown, but it's thought to be due to viral reactivation, probably HSV, in the seventh nerve ganglia. This is a diagnosis of exclusion, meaning that you look for other things on your exam and you follow the patient's clinical course to be sure of the diagnosis. Part of the confusion is actually historical. So Sir Charles Bell was the first to describe the neuroanatomic basis of control of the facial nerve. Bell's palsy then became synonymous with any etiology that caused a facial nerve lesion. Over time, Bell's palsy came to mean the idiopathic version. But when you say a Bell's palsy, do you mean an idiopathic facial nerve palsy, or do you mean the patient has a seventh nerve lesion of any potential cause? So it's best just to leave Bell's palsy on the sideline and use idiopathic facial nerve palsy or a different diagnosis depending on the clinical situation. So let's get back into a case. So this is a 68-year-old woman who has left facial weakness involving the upper and lower face. You can't see the upper face there because of her hair. You'll have to take my word for it. She also has pain in her left ear and pain in her mouth. If you look on the bottom right, you can see that she has a vesicular rash inside of the left ear, and she has a similar rash on the left anterior portion of her tongue. What is the most likely diagnosis? Pause here, look at these answers. We'll talk about them on the next slide. So the best answer is C, but again, let's go through a process of elimination. This is not a middle cerebral artery stroke, as this is a peripheral facial nerve lesion. Now, Lyme disease can be associated with a seventh nerve palsy and a rash, but the rash is usually different, usually has a target appearance, and this patient does not have that. This is not an idiopathic facial nerve palsy. Those patients do not have a rash. And again, we talked about a facial nerve schwannoma. You would not expect a rash, and you would expect a presentation over a longer period of time. So what is Ramsay-Hunt syndrome? So it's got multiple different names, but this is peripheral activation of the varicella zoster virus in the facial nerve's sensory ganglion, the geniculate ganglion. I often think the name geniculate neuralgia is the best name for this condition, as it really describes the anatomy and what's going on clinically. So if you see a patient who has a peripheral facial nerve lesion and vesicles in the ear, vesicles on the anterior 2/3 of the tongue, and sometimes in the roof of the mouth, that's a patient where you want to consider Ramsay-Hunt syndrome. It's treated differently. Antivirals are used versus an idiopathic facial nerve palsy where corticosteroids are used. So it's important to recognize this diagnosis and do a careful inspection of these areas in patients who present with a peripheral facial nerve lesion. And so I do not expect you to memorize all the conditions and all the information on the slide, but what are some signs that you may not be dealing with an idiopathic facial nerve palsy, and it could be a different condition. So if the patient has a recurrence, or if the condition is worsening over a period of a few months, you might consider things like tumors. If the patient presents with a bilateral facial palsy, that's where you consider conditions like Lyme disease, sarcoid, Guillain-Barré. So again, patients who present with a facial palsy at birth could be due to trauma, could be due to genetic syndromes. And then if you have a facial palsy syndrome, so a peripheral facial nerve lesion plus something else. So you have a peripheral facial nerve lesion plus a vesicular rash. Think of Ramsay-Hunt syndrome. You have a peripheral facial nerve lesion and swelling of the parotid and involvement of the eye. That would be a consideration where you consider something like sarcoidosis. And so that's something that you can take forward with you into the clinic. So in summary, so the facial nerve is a motor nerve from facial expression. There are parasympathetic fibers, which, as we talked about, may have clinical significance. And it's very important to be able to differentiate peripheral from central facial nerve palsies. Thank you for your attention. Can't wait to see you all in the labs and the small groups.